So, a very good afternoon, and thank you for holding out till lunch. So many of you sitting here. Thank you, Dr. Gaurav sir, Dr. Saurabh sir, and the entire team at Drishti. It's really a privilege to be here, and I'll never forget this 25th anniversary celebration. Dr. Vikas Mittal has shown these brilliant images, and I will sort of just as a clinician in a day to day practice. I'm not a cornea specialist, but I'm a cataract specialist. And how does imaging help us in our day to day scenarios, in decision making, in teaching, in understanding? Now, I will start with this imaging. And this here, just to build a brief background, is a black and white high speed video imaging. That means the video that is being recorded through a high speed camera is being played 200 times slow, and this helped us to understand and modify our own techniques, and obviously for teaching it is a great tool. So here we are imaging the removal of the last nuclear fragment in a routine cataract scenario, and the idea is to see whether if we have the bevel of the phaco tip sideways, how does it facilitate the nucleus removal, and keep an eye on the phaco tip and the chopper both. Now you see here that the chopper is absolutely dead still, there is no movement of the second instrument, and even the phaco probe is not going here, there, moving, it is absolutely stable, and still the whole nucleus is tumbling inside because of the fact that what we call carouseling, that means when you keep your bevel sideways, whether it's longitudinal ultrasound or torsional ultrasound, part of it should be unoccluded so that the fluid also keeps flowing and it keeps the nuclear material at your tip. And this is actually what helped us refine our technique, and all of us now do a side bevel emulsification. It works better with torsional ultrasound, but even with the longitudinal ultrasound, it will work. So the message here is that imaging taught us that keep your phaco tip not completely occluded whenever possible. Now here is a simple single plane corneal incision, and most of us say that what's the big deal, now all of us are used to doing this. We took the same thing in the same high speed recording, and here is one of our fellows. You can see that it is a new step for the person, and notice when the knife comes out, how there was a sideways swipe, and we feel that no, our incisions were snug and they were self-sealing and there should be no astigmatism, but there are these micro movements happening which if you know, you will try and control and come out in the same plane. And the same thing with an experienced surgeon. Now you see, obviously the hand is much more steady, but the blade is flush with the plane of the sclera, and therefore the incision remains truly uniplanar and parallel to the iris. And like I said, this is being played almost 200 times slow, so please bear with me. But notice when the keratome is being retracted from the eye, it comes out in the same plane and in the same direction. So there is no forward or sideways movement when the tip actually comes out. So these are small points which help you refine your performance, and especially if you are in a position where you can teach others or where you can supervise others, then this is a brilliant thing. Now a few years back we published this ultrasound methodology, and Samresh here did most of the experiments. This is something which was a real eye-opener to us. Just to build a background of what I am showing, this is an ultrasound B scan being performed on a cadaver eye. Phaco is being performed on a human cadaver eye, and at the same time, simultaneously, we are performing a USG B scan. The space between the posterior capsule and the anterior vitreous phase, that means the Berger space, was dissected out manually through a small 30 gauge incision at the pars plana, and it was stained with triamcinolone acetonide. Now believe me when I say that the posterior capsule is intact, because these surgeries were being done under the microscope. I myself was doing them. And you see that when the foot pedal goes from 0 to 1, we see a trampolining or a forward and backward movement of this entire lens capsule complex. Now the same surgery, we raise the bottle height and we raise the flow rate. So that means when you work at 40-45 cc flow rate, obviously you need more fluid going in. So what happens is every time we go from 0 to 1, there are much more pressure fluctuations. The amplitude of these fluctuations is more, and what is noticeable here is these white specks that appeared in the vitreous cavity. What are these? This is basically what we describe as a anterior vitreous phase disruption. In the presence of an intact posterior capsule, the fluid pressure and the trampolining actually led to a functional disruption of the anterior vitreous phase, and therefore the triamcinolone, which was limited to this space, found its way inside the vitreous cavity. This is very, very important because in real life, a lot of inflammatory mediators, microorganisms, all these might be flowing, and sometimes we blame a certain technology or a certain type of cataract for a CME or a vitritis, and you realize that actually you should be working at lower infusions and lower flow rates as much as possible to avoid these kind of clinically invisible complications. Now we move on to more clinical from teaching. Here is a 58-year-old professor, and the right eye had always been weak, and there is a 7-diopter astigmatism on the cornea, as you can see here, and you see this sort of a crab claw, so form fruit marginal degeneration sort of picture. But what is very important to see, as Sir will, I'm sure, highlight and has been highlighted throughout the day, is that when you look at the imaging, look at the pupillary zone. So if we zoom into this image of the topography, this is the mesopic pupil of the patient. So fortunately for us pigmented races and especially elderly people, after a certain age your pupil is not going to dilate more than this. So this black circle is what the pupil was in a dim lighting condition. And here you can see that the astigmatism, although high in magnitude, is very regular. It's a regular bow tie pattern. And this is what the eye trace or the aberrometry showed, that most of the aberrations in the vision were coming from the cornea. And again you see that within this pupillary zone the astigmatism is regular. So we had a lot of talk, and these images here helped us to discuss with the patient, and that this is what your problem is. You have a very high cylinder, which is not the best regularity, but in the center, which your pupillary zone is regular, and this is an older version when the Barrett's calculator was not available. Even with the highest toric model available in those times, the residual was still expected to be 1.5 diopters. But somebody who has worn a 7 diopter, if you can bring them down to even 1.5, it will be a great help in their unaided vision. Also because this was a unilateral astigmatism. You can't expect somebody to wear a unilateral sill of this magnitude. So yes, post-operatively with that 1.5 diopter cylinder, the best corrected vision went up to 6/9, which was a great surprise to us. And the best part is that the patient himself acknowledges that he never saw this well, even with glasses in this eye. So the point is that imaging not only helps you to make a decision, but it also helps you to make a mutual decision where the patient becomes your partner. And if, let's say, in many of these situations there is a lot of expectation mismatch, you can show these images before and after, and like Samresh showed with the eye trace, you can do this with topographies and many other things, where you can show them how much of a difference your surgery made and what it would be without that. But like with anything, imaging is as things become more automated and machine based, also there is a lot of detail that gets missed out, particularly when your practice grows. When you have many machines, you have more technicians, it's a happy situation, but also the fact that you might be missing out a few details when you have a lot of staff turnover. So here is an aberrometry and a placido disc topography from a normal preoperative cataract patient, and you see these irregular Myers here, and this is the corneal aberration profile. And I would think that this is an irregular astigmatism. I would rather not advise a multifocal or any kind of a EDOF IOL in this patient. Now what happens when we treat this tear film, just in the OPD, make them sit for half an hour, couple of times, put a lubricant and repeat this, this becomes absolutely regular and the aberrations completely drop. So suddenly this person is now a good candidate for any kind of refractive cataract surgery. So I think what is also very important is that we prime our staff in and keep regularly conducting training sessions to see that they are actually doing a good quality check on whatever fancy imaging we have. Now this is another example of an optical biometry. You see here the keratometry is about 41 and 43, and the spherical IOL power for a monofocal lens is about 21. This patient was treated for ocular surface disease, and you see that the keratometry changes, but more importantly, even for a monofocal IOL, this is not a multifocal or a toric or anything. Even for your simple multifocal IOL, the spherical IOL power changes by 1 diopter, and all because the keratometry was not captured properly. So I think it is very important that we pay a lot of attention to the head tilt, the chin alignment, the dry surface, because most of it is happening under air conditioning, so we get a lot of dry eyes in these patients. Imaging helps us to understand that whatever we do, basic still remain basic. Here is a slit attachment to the microscope, and this, as you can see, is an emulsification happening very close to the cornea. You may have the best OVD, but this eye is going to have a corneal edema next day, compared to something where you are performing an emulsification very consciously away from the corneal endothelium. So I'm not saying we should have these, but looking at these sort of reinforces the ideas in our mind that we do need to keep looking at these things. These are very old videos, but they're still as educative to me today also. Intraoperative OCT we have all talked about yesterday and today, but again the same principle, where you can see that this corneal fragment, while emulsification, is actually hitting the endothelium and you would not realize it. Now this happens when your technique involves large fragments, or when you do tumble techniques. We don't realize that we are actually doing this. So any form of division, chopping or nucleotomy or divide and conquer, but divide as much as possible and keep your emulsification to smaller fragments. Same thing, you can see the emulsification happening away from the endothelium, and this will be much more, it will show much better results. What actually was an eye-opener for us many years back, and which we published in the American Journal, is performing routine OCT in all cataract cases, and I'm sure most of us now do it if we have access to it. And we found that our retinal surgeon had classified the fundus as normal in pre-op. With a cataract, even the retinal surgeon cannot be a superhuman. But in these eyes, more than 200 eyes, we found that so many patients had these subtle anomalies which were only picked up on OCT. Now this you would classify as a dull foveal reflex and otherwise normal, but see this epiretinal membrane, I would think 5 times before I advise a multifocal IOL, and to prognosticate the patient also. Similarly, this patient, everything looks quite okay except for these drusenoid things, and you see this lamellar macular hole with a vitreomacular traction. So these are things that only imaging will pick up, and yes, down the line, it's a good idea to have access to these. If not, in special cases, like Dr. Vikas also pointed out, please refer them to somebody who does have these. Now, this is something we have worked on for many years, and UBM in pediatric eyes. So preoperatively, like was shown with polar cataracts, you can pick up these things like a pre-existing defect or a lentiglobus, and this is very useful in prognosticating that you may not be able to put an IOL in such eyes. And in pediatric eyes, it's very important that the parents should know of the plan A and plan B, what you are looking at. Post-operatively also it helps us a lot. Something like this, a symmetric bag fixation is the ideal goal, but not every time you will get it. Sometimes, as in this eye, you see that there is an asymmetric fixation. This optic haptic is in the sulcus, whereas this is in the bag. And these are the eyes you want to make sure that your assistants call them every 3 months, 6 months, because glaucoma and inflammation, you do need to look out. So it's not only for making these beautiful presentations, it also helps to change the way you will follow up these patients and put them on maybe anti-inflammatory therapy and prophylactic IOP lowering agents for a longer time. When we do secondary IOLs, either in a child or in an adult where we could not do a primary IOL, I think UBM is very useful. And here you can see that there is adequate sulcus space despite the fact that there is a Sommering's ring. This is a child, so a thick ring is obviously there. Here I am very confident and I will go ahead and do a sulcus IOL. But in contrast, look at this situation where I can see that this entire sulcus space is obliterated. Now in this maximal pupillary dilatation, we know that these eyes don't always dilate to 8 millimeters. You would never be able to make out this unless you had a UBM, and if you go in for your secondary IOL, you are either going to have a very asymmetric or a captured IOL and then add problems to this aphakic child who probably was doing much better and quite okay with aphakic glasses or contact lenses. So I think these are the points I wanted to make. And one last slide on this is again taken on the Anterior, where post-cataract everything looks okay, but these days we all use very heavy cohesive viscoelastics, and please be careful to remove them from behind the IOL. Not only that they will shift your position when they come out, but look at this gap between the lens and the posterior capsule on day 1. So this is a retained OVD, and you want to keep a careful eye on it, and if it doesn't come down in a couple of days, wash it out. Until then, give IOP lowering medication. So thank you, and thank you, sir, once again for the opportunity.